So, having discussed about the acute pericarditis and a brief introduction to pericarditis, now we'll go and discuss about cardiac tamponade. We'll go and discuss about something about cardiac tamponade, a mighty emergency condition. Discuss about cardiac tamponade. So, how will you define cardiac tamponade? Cardiac tamponade is nothing but increased filling of the pericardial fluid under pressure, pericardial fluid under pressure, which is resulting in a reduction in the stroke volume. So quite easy to understand, isn't it? So basically, what happens is there is increased filling. There is so this is the heart. This is the ventricles. This is the chambers of the heart, and this is the pericardial cavity, which houses about 20 to 50 ml of pericardial fluid at a pressure of -2 to -5 centimeters of water. So whenever there is increased filling of pericardial fluid under pressure, it can be due to the increased filling of the pericardial fluid under pressure can be either due to trauma or other causes like trauma or other iatrogenic causes, or we'll discuss the etiology later. So the pericardial fluid, which will the increased filling of pericardial fluid under pressure, which will result in the sudden filling of the pericardial fluid inside the pericardium. The pericardium is nothing but a fibroelastic bag which contains the heart. So it won't be able, if there is sudden filling of the pericardial cavity, it won't be able to accommodate much fluid, and it will start pushing the ventricle. It will start pushing or compressing the ventricle, which will reduce the diastolic filling and further reduce the cardiac output. Okay, so that is what the definition says about cardiac tamponade. So coming to etiologies, what are the etiologies of cardiac tamponade? So, in a study which was conducted in Sweden, out of 340 patients who had cardiac tamponade, 33% of them were secondary to iatrogenic percutaneous cardiac interventions. Percutaneous cardiac interventions. So 33% of them. So basically, almost all of the cardiac, I mean, 1/3 of the cardiac tamponade are iatrogenic. So other than that, the other causes are neoplasms, secondary to malignancies, neoplasms. Then what else? Uremic causes, uremic pericarditis and uremic. It was only minimum, like 3 to 5%. Then other 10 to 12% was secondary to connective tissue disorders. C2, connective tissue disorder. Okay. So now we will go into clinical features of cardiac tamponade. So clinical features is nothing but the classical Beck's triad, which all of us know about. So Beck's triad. Beck's triad is nothing but the triad of hypotension, increased JBP, hypotension, increased JBP, and muffled heart sounds. So we discussed about hypotension. Hypotension is nothing but reduced blood pressure due to reduced in stroke volume. What is called blood pressure? Blood pressure is nothing but cardiac output into peripheral resistance. Cardiac output is nothing but stroke volume into heart rate. So in cardiac tamponade, what happens? The stroke volume is severely reduced as compared to the increase in compensatory tachycardia. The tachycardia is not able to compensate for the decrease in stroke volume, which will eventually reduces the cardiac output and which will further reduce the blood pressure that will result in hypotension. Okay, so next slide. So how and JVP. So having so now before discussing the changes of JVP in cardiac tamponade, we will discuss normal JVP. So what is normal JVP? So the normal wave pattern in JVP is this is the A wave followed by H descent, the V wave and the Y descent. Okay, this is the A wave, this is the C wave, this is the H descent, this is the V wave and this is the Y descent. Okay, The A wave is formed is because of atrial systole. Atrial systole. C wave, we'll discuss the C wave later. It's this in due to atrial relaxation. Okay. So V wave is due to atrial filling. Atrial filling. So Y wave is due to why it's this why it isn't is due to the blood flow from atrium to ventricle or atrial filling into the ventricle. Atrial filling into the ventricle. So we'll look into the detail. So what is atrial system? Atrial system is nothing but the atria contracts against the ventricle, contracts against a ventricle which is relaxing. So the contraction of the right atrium will result in increased pressure inside the right atrium that is manifested as A-wave. So atrial system. So it's what is it's so before telling about the C wave, we'll discuss about the X system. So this is the atrium. Consider this as the atria. The atria is contracting against a ventricle which is in diastole. So atrial systole. Meanwhile, the ventricle is in diastole. Now, as soon as the atria phase systole, it will go to lats. Okay. So atrial will relax. Meanwhile, ventricle will start to contract. So this is what you have to keep in mind. So as soon as atrial contracts and atrial start to relax, the pressure inside the atria will start to reduce. So that is the beginning of the reduction in pressure inside the atria. That is manifested as this is the H descent. This the entire thing is that H descent. This entire thing is that H descent. This can be divided into H dash and proper H descent. So okay. This is atrial systole followed by X descent due to atrial relaxation. This is atrial systole followed by atrial relaxation. Atrial systole, then atrial relaxation. So this atrial relaxation, relaxation of the atria will reduce the pressure inside the atrium that is manifested as the X descent. So when the atria is relaxing, what will happen to the ventricle? So first, when atria is in atrial systole, ventricle is in diastole. After that, ventricle will start to contract. So during the isovolumetric contraction phase of the ventricle is going to contract, and meanwhile the atria is in relaxed state. Okay. So during the isovolumetric contraction of the ventricle, there is the protrusion of the tricuspid valve, which is like this, which is initially like this. So when the ventricle is in isovolumetric contraction, this will project, this will increase the pressure inside the ventricle. So there will be a bulge of the ventricle, the bulge of the atrium and the tricuspid valve into the right atrium. That will be the main cause of C wave in J wave. So first atria contracts, then atria relaxes. Due to it, due to atrial contracts and atrial relax. When the atria is in relaxing, when the atria is relaxing, ventricle will start to contract. During isovolumetric contraction of the ventricle, there is bulge of the tricuspid valve into the right atrium, which is resulting in the C wave. So atria will contract A wave, atria will relax X descent. So when the atria is relaxing, so A wave is due to contraction of the, this is right atrium, this is right ventricle, this is the vena cava. So whenever the right atria is relaxing, there is drop inside the pressure, drop of pressure inside the right atrium. So this will suck the blood from the vena cava into, this will pull the blood from the vena cava into the right atrium. That will cause the ventricular, atrial filling. That is manifested by V wave. V wave is nothing but atrial filling. Okay. So atrial filling, which is caused due to secondary to the negative pressure that is built up due to atrial relaxation. So first atria contracts, followed by atria relaxing. Atria relaxing will create a negative pressure that will result in the atria getting filled from the vena cava. Okay, filled by the vena cava. So that is resulting in when atrial filling, and that is resulting in the EV. So atria contracts, atria relax. Meanwhile, ventricle was in systole. Now ventricle goes in diastole. Okay. Atria contracts while ventricle was in diastole. Then atria relax. Meanwhile, ventricle was in contracting. Now ventricle is also relaxing. Atria is relaxed, ventricle is relaxed. When atria was relaxed, all the blood from the vena cava was entering into the right atria. Now ventricle will also start to relax. So what will happen when ventricle relax? So at this point, ventricle will start to relax. So protodiastole followed by rapid filling phase. So during diastole, the pressure. So this is again the right ventricle, right ventricle, vena cava. Okay. So during the ventricular diastole, the pressure inside the ventricle will drop, and at this time the right atrial pressure is high because of atrial filling by the vena cava. So during then when the ventricle pressure drops due to the pressure gradient between the right atria and right ventricle, the tricuspid valves get opened. So this will result in the filling of right atria into right ventricle. So this will result in a drop in pressure inside the right atrium because of the blood flow from right atrium to ventricle. Blood is flowing from right atrium to right ventricle. Okay. So this will result the drop in pressure inside the right atrium due to the filling of atria into the ventricle is manifested by wide descent. Okay. So this is what is normal JVP. Now we will discuss the JVP changes in case of cardiac tamponade. So what will happen in cardiac tamponade? So what will happen in cardiac tamponade? So in cardiac tamponade, what happens is the Y descent is impaired. Why? So this is the A wave, this is the C wave, H descent, V wave, and I descent. So in cardiac tamponade, what happens is this. This is the heart. This is the ventricle. This is the pericardial cavity. So the filling, because of the cardiac tamponade, the filling of the right ventricle, when right atria into the right ventricle is impaired. So there, because of cardiac tamponade, there is increased pressure inside the pericardial cavity. The increased pericardial cavity is compressing the ventricle. So this will create a positive pressure inside the right ventricle. So it will be hard for the right atria to fill into the right ventricle. Also, you have to think. Also, you have to consider the fact that the volume of the right ventricle is less because of the increased pericardial pressure compressing the right ventricle right ventricle. So this will result in impaired filling of the right atrium into the right ventricle. So which is affected? The Y wave. The Y descent is affected. Atrial filling into the ventricle is affected in case of cardiac tamponade. So in cardiac tamponade, classically there will be absence of Y descent. Okay. The absence of wide cell. In cardiac tamponade, there will be absence of wide cell. So this absence of wide cell. So what will our body? This heart is a beautiful organ. So heart will it try to compensate for this impaired filling of right atrium into right ventricle. So how will it try to compensate? It will try to compensate by trying to increase, trying to fill more blood, trying to fill more blood into the right ventricle by collecting more blood during. So basically the heart is trying to increase that. So the heart is trying to collect more blood during the atrial relaxation state from the vena cava so that it can pump more blood into the right ventricle, which is already compressed by the pericardial fluid, increased pericardial pressure due to cardiac tamponade. So that's why there is prominent expression, and atrial filling won't be impaired. It will be as such, but there will be absent by design. So this is the JVP findings. Prominent expression with absent by design. Prominent expression with absent by design. This is the classical JVP finding in case of cardiac tamponade. So there is something I would like to add on, like there's something called Kussmaul sign. Almost all of you will be knowing about Kussmaul sign. So what is Kussmaul sign and where is it seen? And why am I discussing it in cardiac tamponade? So Kussmaul sign is not seen in cardiac tamponade. Kussmaul sign is seen in uh, Kussmaul sign is in constrictive pericarditis. So during inspiration, there is increased negative intrathoracic pressure, negative intrathoracic pressure, which is transmitted to the pericardial. That is, the negative intrathoracic pressure is transmitted to the pericardial layer, which will lead to a fall in right atrial pressure manifested as a fall in JVP. So a negative intrathoracic pressure will get transmitted to the will get transmitted to the pericardium, which will lead to a fall in JVP. So this is a normal phenomenon. So the absence of fall the absence of fall in JVP during inspiration is nothing but the small sign. So where is it seen? So when the negative intrathoracic pressure is not being able to be transmitted to the pericardium. So this is the condition. This is the case which is seen in constrictive pericarditis. So in constrictive pericarditis, the pericardium is thickened. So due to the thickening of pericardium, the negative intrathoracic pressure is not being able to be transmitted to the pericardium. Okay, so there won't be any fall in JVP in case of constrictive pericarditis. That is called the Kussmaul sign. What else is seen in cardiac tamponade? What else is seen in cardiac tamponade? There will be what else is seen in what else is seen in cardiac tamponade? Pulsus, paradoxus. Pulsus, paradoxus. Pulsus paradoxus is seen in cardiac tamponade. Pulsus paradoxus is seen in cardiac tamponade. So, okay. So in pulsus, what is called pulsus paradoxus? Pulsus paradoxus is nothing but an exaggerated fall in blood pressure during inspiration. If you want to quantify, it is greater than a fall of 10 millimeters of mercury during inspiration. So, is it normal to have a low blood, have a fall in blood pressure during inspiration? Yes, of course it is. So, an exaggerated fall in blood pressure. So, how can there be an exaggerated fall in blood pressure? So, what is the phenomenon? So, in cardiac tamponade, what will happen? This is the right ventricle. This is the left ventricle. Okay. So, this is the cardiac tamponade. So, during inspiration, there is increase during inspiration, there is negative intrathoracic pressure, which is transmitted to the pericardium, which will result in increased filling of the right atrium and the right ventricle during inspiration. So, due to increased filling of the right atrium and right ventricle, there is more blood coming during inspiration as compared with expiration. I'm not saying there is increased filling of right ventricle. I'm saying like there is more filling during inspiration than in expiration. Okay, so when the ventricle is getting filled during inspiration, it can't push the ventricle because there is increased pericardial pressure due to the accumulation of fluid inside the pericardium due to tamponade. So it will push this septum to the left. So this pushing of the shift of the septum to the left will further reduce the stroke volume during inspiration. Okay, so during inspiration, the exaggerated fall in BP is due to the reduction in stroke volume, secondary to the shift of the interventricular septum to the left side, caused due to increased filling of the right ventricle during inspiration. So I'll say it once again. So during inspiration, there is increased filling of the right ventricle. So the right ventricle can't be further further pushed to the pericardial side because of increased pericardial pressure caused due to tamponade. It will push the septum, interventricular septum to the left, which will further reduce the stroke volume and thereby reducing the blood pressure during inspiration. Okay. So this is pulsus paradox. So how you measure pulsus paradox? So pulsus paradox, you have to measure using a BP cuff. So what you will do is you will take the patient to a quiet room. You will take the patient to a quiet room. You will notice the difference in the starting point of Korokov sound during inspiration and in expiration. So the difference is more than 10, then it is called pulsus paradox. Okay. So we have covered the JVP changes in cardiac tamponade and pulsus paradoxes in cardiac tamponade. So what else we had? Of severity in case of cardiac tamponade. So what determines the severity of cardiac tamponade? Some people tell it is pericardial fluid. Like we'll have a tendency. So the amount of fluid getting collected in the cardiac tamponade, the pericardial cavity is the most important determinant of the severity. No, it's not. It's the rapidity of filling. So in a case of acute cardiac tamponade, it takes nearly 200 ml of pericardial fluid to cause tamponade. 200 ml of pericardial fluid to cause tamponade. To cause tamponade. Meanwhile, in case of chronic cardiac tamponade, it takes 2 liters, 2000 ml of pericardial fluid to cause tamponade. Tamponade. So the most important determinant of severity is the rapidity of filling. So in most iatrogenic procedures, most iatrogenic etiologies, there will be rapid filling of the pericardial fluid inside the pericardial cavity, which will result in cardiac tamponade. Okay. So we'll come to investigations. Cardiac tamponade is nothing but a clinical diagnosis which is aided by investigations like ECG, chest X-ray, and echocardiography. In ECG, can you find anything? In ECG, you can find something called electrical alterance. This is nothing but a normal QRS complex followed by a low voltage QRS complex. Okay. So this is mostly associated with chronic tamponade, in which there is a bag of pericardial fluid, a 2 liter bag of pericardial fluids act as a bag of water in which the ventricle is contracting. So inside the car, this called dancing heart site. If you see the CT in the video, you can see it as a dancing heart. So this pericardial cavity will be filled with approximately of 2 liters of fluid. Inside the cavity, heart will be contracting like this. If one systole it will be like this, then it will go to the second systole, it will be like this. The third, it will be like this. Okay. So if you are keeping the electrode here, when the ventricle is contracting to this point, it will have a positive deflection. So since it's a fluid, it's a very large amount of, like, it's a 2 liter fluids inside a 2 liter fluid. So it's like this artery. So this is the pericardium. This is the pericardium. This is the ventricle. So first, when it contact like this, then it will contact like this. So this is the dancing heart side. So inside the CT, you can see it's like a dancing heart. So if you keep an electrode here, so when it is near the electrode, you will have a positive QRS complex. When it's away from the electrode, you will have a low voltage QRS complex. That is the reason for electrical alterance. So what you will find in a chest X-ray? So in chest X-ray, you will have cardiomegaly with sharp cardiac borders. Sharp cardiac borders. Why? Because when it in a normal heart, it will be like pumping. Okay. Normal heart will be like pumping like this. Normal heart will be pumping always systole diastole, systole diastole, systole diastole. So while taking the X-ray, it will be always in motion. Okay. So, but in this case of pericardial effusion or cardiac tamponade, I mean massive pericardial effusion or cardiac tamponade, the heart borders are as such inside which the ventricle is contracting. Okay. Inside which the ventricle is contracting. There is not much movement. Ideally, heart's pumping like this. But in case of cardiac tamponade, it's pumping like this. So the movement is less. So the borders will be much more sharp in an existence. So that is actually more appreciated in the old X-rays than in the distal X-rays. Okay. So in echocardiography, so what all things you will see in echo? What all will you look for in echo? You have to look for the site of tamponade, the quantity of tamponade, whether it can be tapped or not, whether it can be tapped or not. So basically, in echo, how will you differentiate pericardial fluid from pleural fluid? In so when you are so in echo, if it is anterior to the aorta, when you appreciate the aorta, if it is anterior to the aorta, it will be mostly pericardial fluid. If it is posterior to aorta, it will be mostly pleural fluid. So if it is anterior to aorta and if it's in the anterior chambers, if it's in an accessible area, you can directly tap it under the guidance of the echocardiogram. Okay, so you can tap it under sonographic guidance, pericardial cardiac tamponade. You can tap the excess flow. So if it's posterior to, I mean, if it's in like in the if it's in regions we cannot be tapped, we can to refer the patient to cardiothoracic surgeon. They have to immediately take the patient to the OT. So that is what cardiac tamponade in a nutshell.